I decided to pick up a very challenging subject, the relapsed medulloblastomas. So we will start saying that multimodal treatments, including surgical resection, chemotherapy, and radiotherapy, has significantly improved the outcome of children with medulloblastoma in the last decades. And nowadays, around 70% of children with medulloblastoma will be cured. On the other side, there is a 30% of patients who will experience a relapse. And unfortunately, the outcome after relapse remains extremely poor, with survival rates of around 10% at 5 years. The main prognostic factors are the metastatic status, the postoperative residual disease, the histology, radiotherapy at diagnosis, the mixed status, and more recently, we have also learned that there is a correlation between the molecular subgroup with the overall survival, with the WNT medulloblastoma faring much better than the other subgroups, and with the group 3 medulloblastoma having the worst prognosis with only 52% of overall survival at 5 years. If we look at the relapse pattern and outcome after relapse in standard risk medulloblastoma, so the most common situation, we will take into account the results of the COPNET-4 study. Most of us we are familiar with this protocol. 338 patients with medulloblastoma were enrolled in this protocol, achieving an event-free survival at 10 years of 76%. 21% of the patients had a relapse. And notably, I found it interesting, there was also 1% of patients with second malignant neoplasm. Now, 70% of relapses were detected on surveillance MRI, with a mean time to relapse of around 2 years. In the majority of cases, the relapses were at metastatic sites in 82% of the cases, with 80% of these metastatic cases being multifocal lesions, including letomeningeal dissemination. Notably, there were also late relapses occurring more than 5 years from diagnosis in 8% of the patients. How were these patients treated? So surgery was performed in 25% of the cases, radiotherapy in 22%, conventional chemotherapy was the most commonly chosen therapeutical option in 90% of the cases. High-dose chemotherapy was performed in 21% of the cases. Intrathecal chemotherapy administered in 26% of the cases. And the results of all these therapeutical attempts was that the overall survival at 5 years after relapse was only 6%. If we look at the association between the relapse and the molecular subgroup, we found out that group 3 medulloblastoma have a shorter time to relapse of only 1.3 year, that most of the late relapses occur in the group 4 medulloblastomas, meaning that probably we should prolong the surveillance for up to 10 years. Isolated local relapses are more common in the Sonic-Hedgehog subgroup, whereas group 3 and group 4 medulloblastoma mainly present distant relapses. Distant nodular relapses are associated with prolonged survival in group 3 and group 4 medulloblastoma. And as we can see in the bottom on the right, the survival after recurrence is higher in the group 4 medulloblastoma. Now, if we compare the tumor tissue at diagnosis with the tumor tissue at relapse from a molecular point of view, we see that the subgroup affiliation, which is WNT, Sonic-Hedgehog, group 3, group 4, remains stable between the diagnosis and the corresponding recurrence in more than 90% of the cases. But the genomic landscape at relapse may be different from the established landscape at diagnosis, with around 40% of new driver mutations potentially actionable that can be acquired at relapse, mainly in the group 4 medulloblastoma. Now, if we want to talk about prognosis and treatment in children with relapsed medulloblastoma, I believe we have to keep completely separate two situations. The first situation are the infants and young children who have a relapse without having received craniospinal irradiation at diagnosis because of the age. And on the other side, we have the relapses in pre-irradiated children. So, talking about the first situation. Now, we know that standard treatment for infants medulloblastoma diagnosis below the age of 5 years employs craniospinal irradiation sparing strategies in order to avoid the long-term, mainly neurocognitive sequelae. The event-free survival at 5 years is range between 30 and 64%, depending on the study. Notably, children with medulloblastoma initially spared from craniospinal irradiation have a higher salvage rate compared to older children who receive radiotherapy as part of the first-line treatment. And as you can see, the overall survival at 5 years after the relapse is 43%, which means that these patients are salvageable. In the 70% of the cases, the relapses were metastatic, but there is also a 30% of cases where the relapse is a local relapse. This percentage is higher if we compare it with the pattern of relapse in older children. Of course, if these children had received a focal radiotherapy on posterior fossa, the local relapses are very, very few. Median time to relapse was 11 months. Now, in case of a local relapse, in children that were treated with a chemotherapy-only protocol, one possible salvage strategy is the one that has been published by the French group, where 39 children with local relapses of a medulloblastoma were treated with a treatment strategy based on 2 cycles of carbo-VP, followed by surgery, followed by high-dose chemotherapy with autologous stem cell transplantation based on busulfan and thiotepa, followed by posterior fossa radiotherapy. As you can see, the event-free survival at 5 years is 61%, and it's quite satisfying, quite high for this population. Also, we can mention another study from the Canadian group who collected data on a larger cohort of patients, 294 children with relapsed medulloblastoma treated up front without craniospinal irradiation. At relapse, 73% of children received craniospinal irradiation, 25% of children received high-dose chemotherapy, and the progression-free survival at 5 years was 52%. So again, this shows that these patients are salvageable. Poor prognostic factors was the young age at diagnosis, non-desmoplastic histology, group 3 medulloblastoma, as you can see in the curve, and the disseminated pattern of relapse. Now we move to the more challenging situation, the relapses in the pre-irradiated children, which are the therapeutical option that we can propose to the child and to the family. Now, talking about surgery, first of all, as we just mentioned, the majority of relapses occur at metastatic site. Therefore, the role of surgery is quite limited. On the other hand, the surgery in patients with isolated recurrences may lead to prolonged survival, but the benefit is not fully demonstrated. So there are three potential indications for surgery at relapse. First, the complete resection of an isolated nodular lesion or the debulking of a symptomatic mass. Second, the biopsy in order to obtain a pathological and molecular characterization in order to identify prognostic factors and potential therapeutic targets, but also in order to have a differential diagnosis with second malignant tumors or with radionecrosis. The third situation is the palliative diversion of CSF in case of hydrocephalus. Now, a question that was debated in the past was whether or not there is a place for high-dose chemotherapy in this setting. Again, the French group published the results of a study in which they had treated 15 patients with relapsed medulloblastoma with a high-dose chemotherapy with busulfan and thiotepa, in some cases followed by radiotherapy. They report 27% of toxic death, with only 2 patients alive at a long follow-up. So the authors conclude that the high toxicity and the poor long-term survival indicate that this salvage strategy cannot be recommended for the treatment of patients relapsing after craniospinal irradiation. Similar results were also observed in a study by the Italian group. Here also a very intensive treatment strategy was adopted, including 2 high-dose thiotepas, followed by autologous transplant, and in some cases, radiotherapy. Here again, out of 17 treated patients, only 1 was a long-term survival, and it was an isolated spinal relapse, surgically removed and re-irradiated. So, again, the conclusion was that the high-dose chemotherapy strategy has been abandoned for this, is not considered as useful for these patients. So it has been abandoned in favor of a more conventional chemotherapy approach. Here in this table, I try to put together, to summarize the results of the of the more commonly adopted chemotherapy regimens, starting from the old oral temozolomide, which provide, nevertheless, a response rate of 43%. With the time, temozolomide was combined with other drugs, such as the irinotecan. And now we know very well the Temiri because it's a sort of passepartout, transversal passepartout for relapses or refractory tumors other than brain tumors. Then to the Temiri, the bevacizumab has also been added. And here I mention also 2 protocols who adopted another kind of strategy, which is the metronomic strategy, and that seems to provide promising results in terms of progression-free survival at 3 years of 25%. So a little bit, just a few slides to be a little bit more, to see a little bit more in details, a couple of studies. Here there are the results of the COG randomized phase 2 trial, where the Temiri regimen was randomized versus Temiri plus bevacizumab in 108 patients with relapsed medulloblastoma or supratentorial PNET. The toxicity profile was comparable, except for the specific toxicity of the bevacizumab. And we can see that in the temiri-bevacizumab arm, there were more complete responses and less progression diseases. And also, there was a significant reduction in the risk of death in the temiri-bevacizumab arm, and a significant advantage in the temiri-bevacizumab arm in terms of median event-free survival, that was 10 months in the bevacizumab arm versus 5 months in the temiri arms, and also an advantage in terms of median overall survival. Now, I said that the other type of approach is the metronomic approach. What does metronomic mean? Metronomic is something that happens regularly or keeps to a regular beat as if keeping time with the metronome. So metronomic chemotherapy is based on the long-term administration of chemotherapeutic agents at relatively low, minimally toxic doses with no prolonged drug-free breaks, targeting the tumor microenvironment mainly through an anti-angiogenetic effect. The MEMAT chemotherapy regimen is based on the use of chemotherapy backbone with etoposide, cycles of 3 weeks of etoposide alternating with 3 weeks of cyclophosphamide. There are other drugs that are combined with this chemotherapy, and are thalidomide, fenofibrate, and celecoxib. Plus, we have intravenous bevacizumab every 15 days, and intraventricular chemotherapy also every 2 weeks. The presence of a VP shunt represents an exclusion criteria, at least for the intraventricular part. Treatment is administered for 12 months and continued for an optional second year without oral etoposide or cyclophosphamide, and with extended intervals of intraventricular therapy. In case of toxicity, the doses have to be reduced in order to minimize prolonged drug-free breaks. The recent publication in 2023 reports on the results of the MEMAT protocol in 40 children, all previously irradiated, who had metastatic relapses in 95% of the cases, and for whom the MEMAT protocol provided a disease control at 6 months of 57%, and the progression-free survival at 3 and 5 years of 25%. This progression-free survival was even higher, 67%, in children that remain stable at 1 year of treatment. Now, another very debated issue is the ray radiation. We know now that there is more and more an emerging role of ray radiation for recurrent ependymomas, for high-grade gliomas, for DIPG. But ray radiation for recurrent medulloblastomas is very challenging. There is a further degree of challenge due to the risk of complication, as most of the patients have already received craniospinal upfront, and due to the fact that the majority of relapses occur at metastatic sites. At present time, there are no guidelines in terms of dose, volumes, fractionation, and technique. But as a general rule, we keep in mind that the cumulative biological effective dose of irradiation should not exceed 100 gray, and the acceptable interval between the first and the second radiotherapy should be at least 6 months. Here in this table, again, I try to summarize, to put together the information from the 5 existing papers addressing the issue of ray radiation in medulloblastomas. As you can see, the very little numbers, if we put together the 5 studies, we have only 100 patients overall. All of them had received craniospinal irradiation at diagnosis, and were at relapse, they were re-irradiated either with focal radiotherapy, either with craniospinal radiotherapy. The Canadian group reports on the results of focal radiotherapy only, showing that the median progression-free survival is 3 months, and that all the relapses that occur following the re-irradiation are at metastatic sites. And whereas when the more patients are treated with craniospinal irradiation, the progression-free survival at 3 years reached the 25–28%. One of the studies that I think is more interesting is the study from the Argentinian group. Here the authors were able to compare the results, the outcome of craniospinal irradiation versus focal radiotherapy. And they showed that the progression-free survival at 3 years was 31% in patients that received craniospinal irradiation, whereas it was 0% in patients receiving focal radiotherapy. Now, the main concern that we have in mind when we think about re-irradiation is the possibility of having the radionecrosis as a side effect. In these studies, the radiation necrosis occur generally at a mild degree. It was generally grade 1, grade 2 in the toxicity scale, and it was manageable with corticosteroid, except for one case, one patient who died from radiation necrosis of the brainstem at 2 years after the re-irradiation. So we have one death from radionecrosis out of 100 patients. Now, intrathecal chemotherapies. The intrathecal route of administration allows to reach high drug exposure with documented responses in terms of tumor cell clearance in the CSF and leptomeningeal disease stabilization. But it is ineffective on bulky disease or parenchymal disease due to poor drug penetration. The presence of a VP shunt leads to unpredictable CSF dynamics and drug distribution. A possible side effect is the arachnoiditis, which can be managed easily with dexamethasone. Now, target therapy. In medulloblastomas, in the subgroup of the sonic hedgehog medulloblastoma, small inhibitors have shown an objective response in 37% of cases, but only when the activation of the sonic hedgehog pathway relies on an upstream activation, upstream of SMO. It is ineffective if the activation is due to a downstream activation, I would say, downstream of SMO. The major side effects is the growth plate fusion. So the use of this drug should be probably limited only to patients who are skeletally mature. There is a frequent occurrence of mechanism of resistance of SMO inhibitors while on treatment. So treatment should be probably time limited and bridging to other kind of treatment. For group 3 and group 4, there is no specific target therapy currently available. There are only ongoing researches targeting the c-MYC in the group 3 or exploring the epigenetic-based therapies in group 4 medulloblastomas. Now, immunotherapy. Regarding the checkpoints inhibitors, we will say that medulloblastoma are not the ideal candidates for checkpoint inhibitors because they are considered as cold tumors with low levels of PD-L1 expression and low mutational burden. And also for the immunomicroenvironment of medulloblastoma is non-inflammatory and does not recruit immune cell. Probably we will learn something more in the next year when the trial with the checkpoint inhibitors in brain tumors will be completed. And, of course, there is a lot of interest regarding the use of CAR T-cell therapy in brain tumors, but stay tuned because this will be the subject of the next presentation from our colleagues of Bambin Gesù in Rome. So, take-home messages. Relapsed medulloblastoma occurs in approximately 30% of patients and carries a very dismal prognosis. The molecular subgroup have different patterns of relapse and different prognostic relevance. Group 4 have a more indolent clinical behavior compared to Sonic Hedgehog and Group 3 medulloblastoma. When we talk about a relapse in an infant or a young child that was not previously irradiated, we have to consider this child as salvageable, and he has to be treated with a curative intent. On the other side, relapses in children that receive a radiotherapy at diagnosis have a very low survival rate. So treatment decisions should take into account prognostic factors, intensity of previous therapies, time from initial treatment, and clinical status. In case of isolated relapse, a combined treatment including surgery and focal radiotherapy could offer an advantage on survival. On the other side, in case of disseminated leptomeningeal disease, different chemotherapeutic strategies can be chosen in order to prolong survival, but prioritize the minimal side effects and hospital admissions. Ray radiation, mainly craniospinal irradiation, in some cases may reduce the symptoms and provide long-term disease control. But at the end, the treatment decision should always take into account the patient and the family wish, and the choice to either not start or to discontinue the treatment and move to a supportive care only approach should always be considered and discussed with the family and the patient. Thank you very much.
Ευχαριστούμε κυρία Ρίντολα για την καταπληκτική ομιλία σας. Ερωτήσεις ή να το αφήσουμε μετά? Ερωτήσεις?
I have a question. Is there any randomized study showing the value of autologous stem cell transplantation with megatherapy for the relapsed medulloblastoma patients who previously have been irradiated? No?
Not randomized. There are studies, but not randomized. Mainly the studies that I presented. But knowing that the prognosis is very low, they putting on the balance the toxicity and the.
Do we improve the results by doing stem cell transplantation? If yes, then is tandem transplantation, I mean 2 or 3 attempts with high-dose thiotepa or versus just one autologous transplantation? Because
not in a randomized way, but the groups that studied the high-dose chemotherapy, every group tried a different recipe. So in Paris, they tried busulfan thiotepa. In Italy, there was the tandem thiotepa. In the States, they use etoposide and doxan melphalan, for example. Now I don't remember exactly. But what is the difference in the prognosis and in the efficacy is if the child had already received radiotherapy, because autologous stem cell will not salvage the child alone. It will salvage the child if we can add something else, mainly if we can add radiotherapy. So if there is not a resistance to radiotherapy. So children that were treated with the baby protocol without radiotherapy
I mean,
They are salvaged with the high dose, and in that case, it's really worth it to go for it. But in the other cases, no.
The most important thing is how resistant are the cells to irradiation.
Yes.
Am I
Yes.
right?
Yes.
Thank you. Thanks.
Άλλη ερώτηση. Κυρία Κοσμίδη.
Θα ρωτήσω ελληνικά β'.
Όχι. Ναι, εγώ δεν το ήξερα γι' αυτό. Δεν μιλάω τόσο αγγλικά.
Θα απαντήσω στα αγγλικά.
Μιλάει.
Όχι επειδή δεν ξέρω, αλλά για την συνάδελφη στη Ρώμη.
Ναι, όντως παρακολουθεί. Well, my question is, how did we reach in the metronomic therapy in MEMAT to use fenofibrate and celecoxib? I was thinking, you know, I never read about, I never really searched for it, okay? I just got it ready from Boston many, many years ago, and I remember thalidomide, at that time, no bevacizumab, you know, just thalidomide, those two that I mentioned, and alternating cyclophosphamide and etoposide. And I don't understand, I was thinking, you know, that maybe there were some papers stating that people on long-term statins, they don't get some types of cancer, let's say. Or at the same time, you know, those with VOX inhibitors, they don't get cancer. Is this?
No, it was mainly in the old years. They tried. They studied these drugs in preclinical models, and they see that they had an anti-angiogenic effect.
Oh.
So based on the anti-angiogenic effect and the targeting of the microenvironment, they put it together with the other chemotherapies.
And nobody so far tried to remove those.
No,
I
not so
noticed,
far.
you know, it's for historical reasons. Yeah.
Yes. On the other side, because in the paper that has been published, they say we give the full package for 1 year, and after 1 year, we remove the chemotherapy and we go on only with the non-chemotherapy drugs. So they do it in the other way.
Okay.
One last thing, for me it was a big surprise to hear from you that medulloblastoma is so-called anergic. I mean, there is a highly immune suppressed environment, and that is a problem for the immunotherapy or for the targeted therapies, even for CAR T cells.
Yeah.
Okay.
Okay. Thank you.
Thank you very much. Ευχαριστούμε.